Thank you. Um, my name is Ronan Shea, and I'm from Philadelphia, United States. Today I'm going to present a very interesting topic related to different treatments on type B aortic dissection. I have nothing to declare. Because more than 75% of patients with type B aortic dissection actually have no or fewer complications. So right now, the standard of treatment for type B aortic dissection is actually medical treatment. However, after the approval by US FDA of endovascular aortic repair in type B aortic dissection in 2005, its use has increased substantially. But previous clinical trials, for example, instead, were underpowered to distinguish the outcome between the treatments of medical treatment and TAVR. So there exists a need of enrolling a large number of patients in investigating the different outcomes of the treatments in type B aortic dissection. For this reason, we conducted a retrospective analysis on national inpatient sample, which is a large real-world database of hospitalization record from more than 4,000 hospitals in the United States. Our objective is to compare the outcomes of patients receiving surgery, TAVR, best medical treatment in patients with type B aortic dissection. We included a patient with a diagnostic cause of aortic dissection from 2005 to 2012. We excluded patients with aortic aneurysm or who received the procedure which we think could reflect that they had type A aortic dissection. We also adjusted the urgency of the admission. We then compare the three different groups by matching the three different groups. We match according to a propensity score, which was constructed based on logistic regression model. Standard differences of less than 10% were considered a successful match. After matching, we compare the outcomes and survival difference. So in total, more than 73,000 patients were included in our study. We found that for during the study, 8-year study period, the case of type B aortic dissection increased by 20%. The proportion of the use of TAVR increased by 73%, but while the use of the other two treatments actually decreased. And this table showed that this is the patient characteristic of our study. We found that compared to patients who received medical treatment, patients who received procedures were more likely to be younger, female, or receive care from urban teaching hospital. Compared to patients who received TAVR, patients who received open surgery tended to have severe symptoms such as severe chest pain or neurological symptoms, or who had a prior stroke or vascular defects or valve disorders. Compared to patients who received TAVR, patients who received medical treatment tend to have multiple comorbidities such as hypertension, COPD, coronary artery disease, or kidney disease. And here comes the most important slide, most important main part is that we matched 3,612 patients. We constructed propensity score, and this diagram showed that it's a successful match. There was no standard difference in 22 categories. Compared to patients who received open surgery or medical treatment, patients who received TAVR were associated with the lowest mortality as compared to the other two treatments. There was no difference in mortalities between patients who received medical treatment or patients who received open surgery. Compared to patients who received open surgery, patients who received TAVR had a shorter hospital stay, fewer complications, and lower hospital costs. This diagram shows that TAVR was associated with a lowest short-term, which means 30 days mortality rates after diagnosis of type B aortic dissection. So in conclusion, we found that based on the study on the large real-world database of national inpatient sample, TAVR is associated with the lowest short-term 30-day mortality rates as compared to open surgery and medical treatments. There is no significant difference in mortality between the short-term mortality rates of open surgery and medical treatment. And compared to patients who receive open surgery, TAVR is associated with lower medical costs, fewer complications, and shorter hospitalization. Thank you very much. I would like to take some questions.
So, thank you. Are there any questions from the audience?
So it seemed, although the use of Tevar is increasing, it's still in the minority of patients. This is kind of tangential to the data you're reporting, but do you have any sense as to what is limiting Tevar uptake right now?
So the thing is that although there are several studies on Tevar, and it's actually a very heated topic, by the way. Previous studies, they showed that Tevar has better remodeling rates. They showed that the false lumen decrease significantly as compared to patients who receive best manual treatment open surgery in 1 year. They also showed that the true lumen has much more increased than compared to the R2 treatment. However, all of the previous study did not show better mortality rates in Tevar. Either it's an in-state trial, either it's the preliminary data of ASSORB trials or the data from the IRAD. They didn't show mortality rate. So I think there exists some need of investigation, especially we need a very expanding clinical trials. And judging from the fact that the incidence of the LD dissection, type B LD dissection is so low, we need a very long-term follow-up on this. And I would like to also emphasize this, that our study only analyze the short-term mortality benefits. It doesn't analyze the long-term mortality benefit because of the intrinsic limitation of the national inpatient sample. So we only demonstrate 30-day mortality rate. So we need a longer follow-up in a clinical trial. And I think we're still waiting for ASSORB trials to be completely conducted, which is in Europe.
Is there a question from your side, Christine?
I think one of the limitation of your results is that the patient with endovascular treatment were the healthiest, the youngest patients, the less comorbidities. So the one patients are such ill that they have been treated by open surgery, or they have concomitant aortic valve disease. The other ones are too ill to be treated anyway because they have concomitant atherosclerosis or chronic obstructive pulmonary disease. Maybe we should change our strategy and give more patients the opportunity to be treated by endovascular therapy.
Yeah. So our study enrolls a mixed cohort of the patient. It's just one of the limitations, but we also match in trying to covariate. We adjusted the type of admission. In NIS, there is a category, a code that's coding for emergent, urgent, or elective admission. There are nine different criteria for in that type of admission. So I think the emergency of the situation of the hospitalization it has been adjusted, and for the matching, there are 22 covariates has been matching. So we can say that patient probably on the same scale. But as you can say, definitely this is a mixed cohort. So we didn't specify which indication for that is a mixed cohort. For patients who receive palliative care or who receive discharge against medical advice, the slide is not here. All right, it has been excluded too. For patients who against medical advice, surgery not able to be performed, it's excluded. So yeah.
Are there any other questions? Thank you. Great.
Thank you so much.
Great papers. Thank you very much.